allow you to, to do something in the future with yourselves. Oh, how do can I go back? Can I go backwards? I wasn't supposed to. Can I go? Okay. So I'm also going to start with a case, a very short case. I want you guys to pay close attention to it because the next slide is going to depend upon this. So basically, again, with the fake names, it's pretty difficult to come up with fake names, as you can see. And Flower, I literally spent about 10 minutes trying to come up with this fake name. But anyway, this is a patient. His name is Andrew Flower. Not a very catchy name, that is. He's age 35. All right. As a male patient who presented to the therapeutic department on the 13th, note the date, 13th of December 2017. Fake, of course, just for now, for now, but it was fake. The patient didn't really show up there. But anyway, I came to the department with right-sided chest pain, which increased in coughing or respiration. I know a lot of you guys already have some form of diagnosis inside your head already, right? Again, the patient has no history of previous hospitalizations, right? And this is for you guys to read. The chest X-ray was performed and presented to you, which is what I'm just going to do right now. This is the chest X-ray that you have been given, right? This is the chest X-ray that you have been given. Are there any people in here who can actually identify some abnormalities in this chest X-ray? I mean, if you can, maybe just nod, don't raise up your hand or anything else, just nod. Just give like a few seconds, just look at this image and tell me whether you think it correlates with the history that I just gave you. No, right? It doesn't, right? So, first of all, what we can notice is that, look at the name. The name is different, the age is different, the date is different, the department is different, alright? The patient came to the therapeutic department, not the cardiology department. Secondly, this is a female patient, alright? Another thing that you can notice is that from the history, I say that the patient has not been hospitalized before. These are marks of surgery right here, right? We also say that the patient came with acute problem, right? Acute problem, which many of you guys thought was like a pericardial fusion or something like that, right? I mean, pleural effusion, for example. But here your patient has cardiomegaly, all right? So, okay. As long as you guys understand that. Another quote from Dr. Wayne Dyer states that if you change the way you look at things, the things you look at change. Alright? So most of us, when we're given an X-ray or some form of imaging, sometimes we feel defeated. Alright? Already we feel defeated because it looks like it's something that specialists should be doing. Right? But in actual terms, that it is something that we can all do. It's just a thing that we need to do. Just like understand the basics first. Understand the basics, and everything will be possible. So again, the steps in assessing a normal chest X-ray, it's the who, the what, the who, the why, and the when. Who being who is your patient. Know that you have the correct X-ray. Know that this is the correct patient whose X-ray you're going to read, right? No, that was the who. Okay. And the what? Know what it is. It's a chest X-ray. It's an ultrasound. It's an echo. You understand? It's a CT scan. It's an MRI. Know what it is, right? And why? The history. The history, like we already spoke before, that understanding the history of your patient is paramount in you being able to read your X-ray, because it gives you some form of mental picture as to what you expect to see. And the when, again with the date, know when the image was taken, because your patient can come to you with 10 X-rays and then you can actually report upon the wrong one and give the wrong diagnosis, basically. Can I go back, please? Sorry. Again, note the fake name. It's very difficult to come up with fake names again. There's no what you call hopefish. Basically, this is just what I said about the importance of knowing the history, right? Because it's like how can I put it? It's like if somebody comes to you and tells you that I broke my leg, immediately inside your head you can picture what a broken leg, what a broken bone is going to look like. It's going to be disconnected, right? And so that's why it is necessary for you to know give history, so that you can have something to build upon when you start reading the X-rays. So the second thing is knowing the projection. What projection are you looking at? What when you're given a, today we're going to talk about X-rays, and later on we'll talk about some other things. But right now we're talking about X-rays, and you need to know how was your X-ray taken? Was it taken in the lateral aspect, like this, with the hand up, or was it taken in the anterior posterior? Looking at it, like how you're looking at me. It is also necessary to know this. Is there rotation? Rotation is something that can really confuse a lot of people and can lead you to actually putting a wrong diagnosis, because when your X-ray film is rotated to the left or to the right, what happens is that the things which are central move to the side, and you can start thinking of, I'll show you an image right now. Okay, this is how you tell whether your X-ray is not rotated or not. You can read it over here. It says that the spinous processes, the medial ends of the spinous processes, no, of the clavicles, I think it's I wrote the wrong thing over there, but the medial ends of the clavicles, here's one, and here's two, must lie medial. I keep on pressing this thing, sorry. Must lie medial to what? The spinous processes here that you can see, right? And this is a schematic image of it. You can see that the spinous processes are in the middle, and the medial ends of the clavicles, to the sides of it. So this is not a rotated film. Now I'll show you a rotated film right now. This is a rotated film. As you can see, the clavicles are not medial to the the spinous process, which should have been over here. So what I was saying is that when your patient is rotated, the medial structures can move to the side. And for example, right now, you can actually think that this person has scoliosis, for example, if you did not notice that that is rotated. And so it is necessary to know whether your patient has been rotated. Basically you need to know how the film was taken. And this is a schematic to show you what happens when your patient gets rotated. Medial structures get shifted to the side, and the clavicles, you can see one end better than the other. So in this case, this patient has been rotated to the right, as I presume. It should be rotated to the right, I think so. See the clavicle end over there, and okay. Also, another thing is exposure. A lot of problems that we encounter, for example, here at school, is that you can be given a poor quality image, and then you'll be expected to give a conclusion upon that. And I think that personally, as somebody who's going to give a diagnosis upon an image like this, you can actually deny an image and say, no, this image is not technically good for me to actually report upon. Because, for example, this image is too bright, right? As you can see, it's too bright. You can't see a lot of things over here. And if you as a doctor then go ahead and report upon something that's too bright, you'll probably give the wrong diagnosis, and you'll be held accountable or something like that. And this is when your exposure is too dark. I think it's too dark. You can't see again the structures. And this is when your exposure is good. Everything gets shown. You can see everything there. Don't worry, we're going to go into the anatomy just now. I'm just trying to move as quick as I can. Okay. Also, another thing, is your whole chest showing? Is the whole chest showing in the X-ray? Because sometimes you can be given a film which has been cut. For you to give a full summary upon an X-ray, you need to see everything, right? You need to see everything. You can't report upon half and then assume what the other half could be, because maybe your problem could be underneath there, So it's also something to take note of. Also, another thing to note is expansion. I know everybody here has had a chest X-ray taken. They tell you to breathe in, right, and hold your breath while the thing's being taken, right? This is an example of good expansion, right? I'll tell you how to notice, how to tell whether your X-ray has good expansion. There are two ways of checking it. Oh, I don't know what just happened. Oh, okay. First of all, you can assess the posterior aspect, right? You can check the posterior 10 ribs. You can see posterior 10 ribs, or you can see the anterior 6 ribs, right? I'll show you how to count them. For example, I'll take a look at this rib over here. No, we just start from the top. We can count them: 10, 10 posterior ribs, and then we'll also count 6 anterior ribs, right? Count number 1 is over here. See, rib number 1, number 2, number 3, 4, 5, 6, 7, 8, 9, 10. Good exposure. Now let's look at the anterior aspect. Here's rib number 1. 1, 2, 3, 4, 5, 6. Good expansions, right? Schematic. Yeah, I'm pressing the wrong button. Or can I just go to the next one then? No, it's me. I don't know what I was doing. Okay, so it's 0.4. Okay, so this is a schematic for you to understand the anterior ribs when you're looking at the expansion part, right? So, okay, poor expansion. Already you can suspect that there could be another pathology over here, right? Just by looking at what you see, you can actually think that that is air beneath the diaphragm. You might think that is air under the diaphragm, right? You might think that this is cardiomegaly because the heart is looking pretty big over here, but in actual fact, your patient just did not take a deep breath in. You understand? The patient there's no adequate expansion to this. Here's a schematic. How many ribs can you see? You can see 1, 2, 3, 4, only anterior ribs. But usually you're supposed to see what? 6. Or the posterior 10. Okay, so let's just look at some anatomy really quickly, just for you guys to further understand what we're going to talk about. We'll look at number 1, which is the clavicles. You can touch your own clavicles, you have them over there. 2 of them. Everybody has 2. Some people have 1, which is a very rare case. You can look at the rib. Like I was trying to tell you guys, that the rib has an anterior and a posterior aspect. Look at the number 2 here, shows the posterior aspect of this rib. And number 3 shows the anterior aspect. Alright? And number 4, you're looking at your costodiaphragmatic sinuses, right and left. Very important to note these things. Make sure that your image always shows these things, right? I mean, you can see the level where they are. Number 5, okay, the right one. The 6 and 7 are the lung, the hilum. You understand the hilum, like the entry point into the lung. Looking at another point, look at the trachea. Right, marked in blue there, which bifurcates at the carina, apparently. Then number 3 would be the valve of the aorta or knuckle, something like that. There are many names for this thing. I just call it the valve of the aorta. It's always on the left. I mean, most of the time it's on the left, so it's a marker to show you whether, left or right side of whatever of the heart. Looking at your descending aorta here, number 4. Can't really see it sometimes, but it will be there, right? Look at your left heart border, right heart border, then your hemidiaphragms, right and left. For short, okay, when we get to that point, I'll tell you, but just know what they are, all right? Okay, so now we're going on to the reading, the actual reading aspect of it, because we previously were talking about the technical part of it, which is step 1. Step 2 is actually reading the X-ray now, right? And in this case, I want you to remember your A, B, C, D, and E. Common for a lot of people here when you do your emergency, I don't know what the subject is called, you understand, right? A always stands for airways, B is breathing, C circulation, D is disability, E, in this case, no, my own perception of it will be everything else, even though for other people they'll call it exposure, but for me it's everything else. So when we're talking about airways, we're looking at are there any changes to the principal bronchi distance, right? We're looking at presence of tracheal deviation. Is it deviated to the right? Is it deviated to the left? Because the pathology in the chest can cause these. Can we go backwards? It can cause these changes, and also. One thing which you must note is the carinal angle, which is this thing right here. Right, in normal it's 40 to 100 degrees. Right, so it's just something for you to know that sometimes when you have, for example, a massive heart problem, for example, or something that causes compression of things inside the chest, just know that this thing, since it's a bifurcation, it can be pushed up. When you push it up, what happens is that this angle is going to open and become greater than 100. And sometimes when you look at your X-ray, it's something, it will point out a few things when you get there. So, breathing. Is there uniform lung expansion? because it's something to note, right? If your lungs do not expand equally, then obviously there's a problem there, right? Compare the lung fields, left and right heart. Left and right lung. Is it normal? Is the color the same? Are there any opacities there inside the lungs? Is there a lung on the left side? You know what I mean? Something to note. Assess the diaphragmatic sinuses, the things that we spoke about before, right? Check the lung edges, because you also need to check those as well. You must assess everything when you're looking at the chest X-ray. Then assess the 4 silhouettes, which I shall show you right now. So, first one shows you the right heart border. The second one shows the left heart border, and 3 and 4 are the diaphragms, right? These are your 4 silhouettes, and they will come handy when we progress forward in this presentation. C is for circulation. We're looking at the cardiac size, looking at the great vessels, and also looking at the mediastinum and the lung hilum, right? Because there can be changes there as well. So, quick note on how to assess the cardiac size, because at times we can rush and say that it's cardiomegaly without actually calculating. It's just like how in therapy, you have left ventricular hypertrophy, right? Some people can just look at an X-ray, an ECG, look at V1, see maximum R wave and V1, and then you say that's left ventricular hypertrophy. No, sometimes you can actually calculate these things, right? With left ventricular hypertrophy, you can calculate. There's an equation there as well. So in this case, you can calculate it. You calculate the widest, the maximum distance between the thoracic wall, in the chest wall, and the diameter of the heart, right? Just by looking at it, right? And normally the ratio between this diameter of the heart and of the thorax is usually less than 0.5, i.e., the heart is never bigger than half of this diameter, right? Disability, which was D, I think so. I hope it was. For disability, we're checking for ribs. Is there any evidence of fractures? We're looking at the shoulders. We're looking at all the joints. Looking at the clavicle. Looking at the vertebral bodies. Loss of height. Also, if you're looking at the spine, you're looking for any scoliosis or anything, any curvatures in the spine, right? So tips. You can go back there. These are just a few tips I came across. It says always check the clavicles. Again, clavicles you can check for rotation. Check, see if they're broken or anything like that. Check the scapula. A lot of people mistake the scapula for a lung border. The blade of the scapula for the lung border. So necessary for you guys when you go back home, just assess and see where the scapula is, right? Checks the proximal humeri for the shoulder joints. Sometimes you take like a broken shoulder or something like that. Check each vertebral body, and this is a tip which I also learned, is that when you're assessing for rib fractures on an X-ray, which is very difficult to point, you can tilt the film 90 degrees and try to trace the ribs, one by one, and hopefully you can actually find your broken rib. And again, this is something which we were taught in surgery class. It said that if there's a collapsed lung, there's a chance of a rib fracture, right? So something you just note over there. Then for E, which is everything else, not everybody else, you're looking for example, surgical interventions, looking for drains, looking for sutures, looking for pacemakers. All these things you need to know. Also, something which people forget to check is the lung apexes, apices, or lung apex, singular. Right? Also check behind the heart, which is very difficult for me. Check below the diaphragm, because you can notice the pneumoperitoneum if you look underneath the diaphragm. Also check for soft tissue abnormalities, which are very easy to miss, but will be so obvious, yet it's so easy to miss. Inside the soft tissue, Hopefully I put an X-ray which has this, so for you guys to see. Okay, looking at the chest drain over here in the right lung, right? You can see it, right? Trace it outside, right? I'm not going to talk about why the chest drain is there. This is just to show you guys what a chest drain might actually look like on an X-ray. Looking at surgical interventions, these are, this person had some fractured ribs and they fixed it up, right? If you remember even the first X-ray which I showed you, it had some surgical stuff going on over there. Pacemaker. So don't be confused when you see these things, right? It can help you in formulating your diagnosis. Assessing underneath the diaphragm for pneumoperitoneum, which will be an abdominal pathology, which we're not going to talk about today, but just know that it will point out an abdominal pathology. And as you can see, there are other things over here, other pipes and surgical things going on over there, right? Which we're not interested in today because we're talking about the chest and the abdomen. So, before we start going into all the images and things like that, I think it's just necessary to just lay down some more basics. For example, for CT is something which is pretty difficult sometimes for some people, but it's actually pretty simple. Denser substances absorb more X-rays, and if they absorb more X-rays, what color do they say to be more attenuated, i.e. they display whiter. For example, calcium is white, right? Even on X-rays, things like calcium, metals, and those things, they're dense substances, and so usually they are whiter in color when we look at it. Less dense substances, such as air, don't really absorb that many X-rays, and so will appear darker, right? So if you have a mixture of dense substances and air, for example, inside your lungs, what color your lungs are going to be? They're going to be gray. It's a mixture of black and white, right? So, CT is measured in Queensfield units. I don't know how to pronounce this one correctly, but I already said it, so I'm not going to repeat it. Just in case people want to take video of me and after me later, I'm not going to repeat it. So basically, you can see, like what I just said, that the bone, which is very dense, has, it's over there, it's in the white spectrum. Air is in the dark spectrum. So the lungs will be in between because they contain soft tissue and lung and air. So it's a mixture, black plus white equal gray. Okay. And the planes which we use, not we, because I'm not really there yet, but which they use in CT which they use in CT or MRI, because I'm not going to go into MRI today, but just want to talk about CT. They use the sagittal plane, as you can see this one, and they use the frontal plane or the coronal plane, which divides it into anterior and posterior, right? And they also use the transverse plane, superior and inferior, right? So windowing, something which is very important, which can actually confuse a lot of people. Windowing is in a sense contrast enhancement, i.e. you're editing your picture so that you can see something else. You understand? Just like with your Instagram posts and those things, you have your filters, right? You change some aspects of it so that you can highlight certain things. Sometimes I want my eyebrows to be seen properly, so I'm just going to change the contrast a little bit. So in this case, we have lung windows, mediastinal windows, and bone windows. I shall show you images of each. So basically, lung windows, it makes it easier to see the lungs. Mediastinal windows makes it easier to see the mediastinum and blocks out the other things, right? Bone windows, good to see the bone, right? So let's just now we're talking about the images. So looking at the different levels, when we're looking at transverse sections, we can talk about levels, slices, right? So at this level, which is called the aortic arc level, typically through the name we can tell what we're supposed to see. We're supposed to see the arc of the aorta there and there. So basically this is a lung window. As you can see, the lungs are more defined over here, right? Everything else is just whiter. Even the mediastinum is a little white. You can't really see what's going on. This is a lung window. And this is a mediastinal window, right? I.e. your lungs become dark so that you can see what's in the center. And at the level of the main pulmonary artery, I didn't take all the levels, but this is the main pulmonary artery level. You can see the pulmonary artery over here, right? See it's bifurcating and forming the left and right branches into the lungs. You can see the aorta over here, the starting part of the aorta, and you can also see the descending aorta. You can see the trachea there, which is always going to be black because it contains air, right? High cardiac level, again you can see the heart, you can see some of the structures over here. I'm not going into detail with that one. So rib fractures, easy to miss on plain X-ray, like I said. Sometimes we have to use ultrasound and CT because they're more sensitive, and in CT we're going to use a bone window, like I said. Oh yeah, this I wanted to show you guys a rib fracture, just one. I mean, there are many of them, but in this case I'm going to show you guys one. So if you trace these ribs over here, right? You go to the next one. You see that here it's not continuing over here, as you can see. For the next one, you see it's broken, right? It's 100%. See? The next one, you see that there was a fracture over there, right? And this was a 3D reconstruction of it, and you can see the fractures right there. And so that's why with some pathologies it's better to choose other imaging modalities so that you can see what's going on. So now we're going to talk about some common findings. As long as we keep searching, the answer comes. This is a quote by this guy over here. I don't know how to pronounce the name. You guys might laugh at me, so I'm not going to risk that. So case one says that a patient, fake name again, note how we write these things. Well, how I wrote the thing, it says patient's name, age, the date, chest x-ray, posterior, anterior view, right? Short history, sudden onset of low blood pressure, weak pulse, muffled heart sounds, raise in jugular venous pressure. You're already suspecting something, right? Look at the heart, look at everything, right? When I measure the size of the heart, as you can see, if we were to measure it, you can notice that the heart is it's enlarged basically, right? And as you can see, the silhouettes are increased, the right border increased, left border increased, right? What can we suspect? We can suspect either cardiomegaly, right, or pericardial effusion. How do we confirm this? You do a more sensitive test. You do CT, MRI, or echo, right? This is a CT scan, a found CT scan, which will show a pericardial effusion. As you can see, the fluid here around the heart, which is colored in black in this case, and again over there. This is a mediastinal window, as you can see, because the lungs are black. Mediastinum is what? Visible. Watch that. No, that's not it. That's not it. There's a lot more stuff there. There's a lot more stuff. Right. No, it's not finished. No, that's not it. That's not it. I don't know what happened.